So this brings us now to our speakers. Rodrigo Navarro, who's been here. Rodrigo, you got a sense, 7:30, right on time. We get a sense of the things going on in our department. Rodrigo is a extraordinary colleague. He did his residency in neurosurgery in Mexico City. Then he came in during that time and did an unfolded postdoctoral fellowship at Johns Hopkins when I was there. Did a tremendous amount of research, published some wonderful papers with our team. Then went back and got his master's, and again, then went on to do a clinical and basic spine research in Cornell, and then an AO spine, also research in McGill and scoliosis. Went back to become staff in neurosurgery at McGill, and then most recently in 2021 became an instructor in neurosurgery at Cornell. Tons of awards, tons of recognition, beautiful papers. You can actually see his age index, both by Google and SC, and you can actually see the impact that he's got in the literature already. In 2022, he's got about 35 citations. As you can see, this is our team. This is the impact that our speakers have on the world. I wanted to just welcome Rodrigo. He is not only an extraordinarily talented individual, but he's also an amazing human being who has been a tremendous friend and colleague, and who has helped us, of course, in building new bridges. And we are excited to have you here, Rodrigo. So please take it away. We're very blessed to have you and looking forward to your talk.
Oh, thank you so much. That was an impressive presentation. I didn't know I have done so much. But it looks better when you are saying it.
Beautiful.
So, thank you so much for that presentation, Dr. Key. So yeah, let me share my screen. You see that now?
Yes, sir.
This
All right,
perfect.
so this is me, Rodrigo Navarro. I will talk about total navigation and augmented reality. So how we implemented this into our practice here at Cornell. Thank you for having me. These are my disclosures. None of these will be approached here. So the goal of this talk will be to show you how we incorporated 3D total navigation. This is a concept. I will explain this to you. And augmented reality in our practice. This is the idea from Simon Sinek's, the author, book author, bestseller of the Golden Circle, which he basically explains that there's like three parts of this circle, which is the what, the how, and the why on every successful leader and organization. What being to know what you're doing, how you do it, and most importantly, why are you doing this? So what do we do with navigation? We do screw placement, we localize pathology, we navigate anatomy, we confirm level, we avoid damage to critical biomechanical parts, such as the pars, the facets, the vertebral artery. We also are able to replace fluoroscopy, and we can plan and assess our hardware preoperatively and intraoperatively. Also, in more recent days, we're able to integrate this with robotic surgery, with deformity correction, and also rod placement, which is not easy in a big scoliosis cases. How we navigate. So there are different ways. This is some material we published before in different publications, but we have been going through this ladder of fluoroscopy, cone beam CT, fan beam CT. Just so you know, fan beam CT is the true CT scanner. This is the one we have here. It's an intraoperative CT scanner, like low profile. With this technology plus some additional software, we're able to do all what we do here, which is total navigation plus now augmented reality. And I will show that in a minute. Why we do this? So we do it because this has been proven to be safe and increase accuracy in screw placement and hardware placement, especially in very complex redos and big degenerative scoliosis cases. It also improves efficiency, at least in our OR, we have proven that, and I will show you as well a couple of videos about that. In terms of time, cost, and workflow, enables complex and MIS procedures. It improves patient satisfaction and outcome, and also improves recovery. As you know, in navigation for brain tumors was as well the way it is right now, a tool, and now is a gold standard, right? So this decreased the numbers of wrong side surgery dramatically. And I think this is the same thing that is happening now with navigation and spine surgery. This is a recent publication done by an author here at New York Stony Brook, which gathered approximately 20 articles from 2007 to 2020. The most significant of them is this one from Modi in 2008. He sent a survey to all the members of the AANS, around 3,000 and something members, 450 replied. And it was obviously an anonymous survey, and 50% of them responded that they have a ground level surgery in spine surgery during their career. So this is significant. So this is something that is happening very commonly. And this is why navigation in spine surgery is so useful these days, because it prevents this. So navigation in spine surgery, just to give you a summary at this point, increases implant accuracy, facilitates MIS, which is what we do here at Cornell, complex and cases and deformity, eliminates wrong level surgery, and eliminates fluoroscopy. So this means total navigation, our concept, which is elimination of fluoroscopy. We don't use fluoroscopy, we don't use lead, and we don't use K-wires. So for those doing spine, you know that K-wires can be also harmful. And also it allows us to assess immediately during surgery the position of the hardware, the correction of deformities, or the state of the procedure. If we integrate this with robotics, it allows us to plan and do automatic processes as well. And most recently, we have been integrating this with augmented reality. This is our concept. We described it in 2017. And we analyzed 150 patients, and we noticed that we eliminated fluoroscopy, means like zero radiation for the surgical staff, in 75% of all our spinal cases. This includes every single region, cervical, thoracic, or lumbar. In 75% of them, we were able to eliminate fluoroscopy completely. And just to mention, as a brief note, the basics of this, of successful navigation practice, is drape and tape. So we tape every single patient to the table, just because we need to make sure that these patients are fixed, or at least stable enough to prevent any shifting. We also have to plan it very well where are we going to place our reference array. For those using cone beam CTs, you know that the field of view of the machine will be approximately 30 centimeters. After that, you will start getting inaccuracies. In our case, for this one is 60 centimeters, so we have a better profile. We have to confirm accuracy with anatomical landmarks always. Try not to push, try not to hit, try not to use osteotomes. It's better to use the drill to prevent shifting as well. And every time that you do a brisk movement or like manipulation of the spine, which happens every single time, you might be able to reconfirm accuracy. This is where we place the reference array. For the cervical cases, we place it at the matrix holder, and for the upper cervical as well. For the upper thoracic, we place it at the spinous processes. For the lumbar and a lower lumbar spine, we place this in the iliac crest with pins. And sometimes when we do lateral, we have to navigate it anteriorly, we can either put it at the table. So as you see, we can use it for localization of pathology. This is a case of a thoracic disc. This helps us to dock the dilator retractor in place. We use it for posterior cervical foraminotomies. We use it to localize thoracic tumors, in this case, like a schwannoma. This is a case we did a couple of weeks ago, which was a patient complaining of radicular symptoms on the left side. Nothing on the sagittal is noted, but when we see the cut of the pelvis, we found that tumor on the plexus. So he got an additional MRI with contrast. We showed that schwannoma. And then how can we use this efficiently? So we use our approach, which is putting the pins and the reference array and the anterior iliac crest. And then this facilitates the approach for the vascular surgeon and also minimize the invasiveness as well for them. So they are able to navigate as well if they are in doubt where they are, or how far they have to go, or how low they have to go, or how caudal they have to go. They can use the probe, and this also helps with the communication between both. So we know where they are. We don't have to be in the field with them they can just point it out on the screen. This is a far lateral disc that I did just recently as well. And this is an obese patient. So MIS and navigation is extremely helpful with obese patients. This is a patient that had this far lateral disc at L4-5 on the left side. And this is the navigation during the surgery. Obviously, you have to avoid damaging the facet and damaging the pars. And that's what I was doing here. And I was able to dock and navigate right to that Campbell's triangle without hurting the nerve. Then following the disc to the side, and you can see how I'm a far ventral on this disc, and I was able to remove the disc. This is another example of how useful navigation could be. This is a patient that came to the ER paralyzing the same day that had surgery and unknown history of cancer. He had a full MRI of the cervical, thoracic, and lumbar spine, finding this lesion that was of concern. Obviously, this patient was taken into the OR. The radiology report was, no offense, but the radiologists here are amazing. The radiologists here are amazing. However, in this case, the reading was lymphoproliferative tumor. So for those that have done these kind of tumors, they know that these tumors are soft. So in this case, the tumor was not soft. The tumor was a blastic bone lesion, most probably prostatic cancer. So navigation was extremely helpful to drill those pedicles and go all the way anteriorly and ventrally to try to decompress the spinal cord. At the end, the patient did excellent. He's now at home walking with that short construction because the bone was so hard that we didn't feel the need to continue the approach and fuse this further. And we use as well navigation for the routine procedures, for everything, for the routine TLIFs and also the challenging ones. This is one that I will show as well with augmented reality, in which you can see that there's a bone defect, a small node eroding the bone at 4-5. And obviously we're trying to avoid that because we're thinking that this patient had the biomechanical pain and needed a fusion. And with navigation and augmented reality, we were able to perform this successfully. So I will show you the case later. And also we use it for ACDFs. So a lot of surgeons say that it might be not accurate. We have found that it's pretty accurate in our hands. So we put the patient fixed into a table with a Mayfield head holder, and then we put the reference array on the Mayfield head holder, and we're able to navigate this way. This is just a few of the most common cases that we do. Not this specific case because it's a 2-level TLIF, but we do TLIFs and decompressions every single day with this kind of technology. So this is a 70-year-old male with neurological claudication, right thigh pain, and L3 dermatome pain distribution who has failed conservative measurements. He has a 2-level stenosis, L2-3, L3-4, with also a disc on the right side, L3, L4. So we consider that based on this and his overall alignment, this patient was a good candidate for a fusion, decompression and fusion. We don't think that with a simple decompression, this patient would have been doing good. And with a fusion, we also didn't think that we would send this patient into a degenerative scoliosis. So we have described these steps. I won't go into details because this can be found online, the steps of the TLIF. And our workflow is planned incision on the skin with the aid of navigation, 2 incisions, fascial incision on one side where we're going to do the facetectomy, and just one on the side where we're going to do the screws. This is the new set of screws that we have here. Probably you have it there as well. Is the single pass instrument, which has also a K-wire incorporated into the system, which is retractile. So you can also insert, and then once you're passing the pedicle, you can retract and make sure you are not damaging anything at the front. We localize the end plate and the disc. This is very important because most of the patients that we do here have severely degenerated disc, almost bone on bone, and we still are able to put expandable cages in this setting. I think it's a lot because of the navigation, because we can plan the cage, we can plan the size of the cage, the length of the cage. And in this case, we were able to implant those cages perfectly and the screws and expand them without any issue. As you can see, the overall alignment of this patient was preserved. We intended to do. The patient is doing great today. And I think we were successful with this. This is another case, a multi-level LAMI. This is not just not a case that we do that often, but it's a case that I found that it was interesting to show because not many people is doing this. This patient I have trained at McGill, which is like a scoliosis spine center, and probably this patient would have had a long fusion there. And this patient was trying to avoid that because he was very active. He was, after the pandemic came, he was just starting to work again. So he couldn't afford being just in bed or recovering from this. So he was a 63-year-old male with neurogenic claudication, 4-month history of weakness, very active. He also failed conservative measurements. As you can see, he has a pre-congenital stenotic canal here with multi-level degeneration. So in these cases, what we do, or what I want to show, is that we try to prevent pars defect or pars lesion. So what we do is we drop a pin, a marker, into the pars during navigation, and then we work around it in a slalom fashion to minimize biomechanical instability. And this has been published before a couple of times, and it's actually helping biomechanical instability and preventing this. So now let's move on after I show what you probably already do with navigation. Just to show you how we incorporated this, I will show you how we incorporated augmented reality into our approach. So we thought that we have done enough navigation, and we were not ready to move full force into robotic surgery because of the characteristics of the robots these days. So we wanted to improve our management. So what could we do? So augmented reality. Augmented reality, as you might know, is the enhanced version of reality based on superimposed computer-generated image of the real world. In this case, for us, will be the anatomy and the patient. So we have to overlap images from the anatomy into the patient during the OR. So we describe total navigation in a series of procedures that we did before. So we felt very comfortable describing the steps of the TLIF. So we thought that if we were going to do this, we were going to start doing it on a procedure that we have standardized here, and that we have a series of steps that are reproducible and that can prove our concept. So just to mention, in 2015, using the ISO-C arm and using a navigating guide tooth, this is the workflow, and it will take us around 6 minutes to place every screw. So this is just the average. We'll have to calibrate the navigating guide tooth, then put the screw, which was a headless screw, then put the tulip over the top of that screw, and then connect the rods. What we are doing now in 2022 or 2021 is we mark this, we bring the scan, we bring the fan beam CT scanner, everyone leaves the room, we localize the level, we use the single pass screws that have this sharp tip, and then we just tap over the bone, we proceed with the navigation. We can also graph iliac crest graft for this to secure our fusion. And so we can also drop the tooth and find the margins of our approach. So we know where we are, if we need to go lateral, medial, caudal. So we know everything with this. And this is the actual reconstruction of the CT scan during the procedure. So we can assess everything, including expansion of that cage. So at this point, we felt very comfortable. Let's give it a minute. I think this froze. We'll restart the. So
I think your presentation shut down, Rodrigo. Is that what happened?
Yeah.
It's just
Working
trying to reboot. There you go.
Yeah, I got it. So I was mentioning about that we were very comfortable with the steps of the MIS TLIF at this point with the navigation and incorporating the steps that we also described. So what we knew is that, okay, we know that this is a single stage procedure. We know that it's effective. Can you see my screen there?
It looks good. We see it.
So it was a common procedure we do here. We wanted to be reproducible because the way we wanted to incorporate augmented reality in our setting was to make it reproducible for teaching, for teaching purposes. So everyone could know, since we already know the steps, the PAs, sometimes they know the steps, the residents know the steps. Why not incorporating augmented reality and then making this more efficient? So we reduced the learning curve. We knew that anatomy was challenging. So what was the next step? So surgical landmarks. And this is a project that Fabian Sommer from Germany is doing with us, which is he identified these landmarks that we wanted. We marked the pedicles, we marked the facet, we mark in red the starting point for our drilling and the ending point for this. So this is for the facetectomy. And we also mark the disc and the contralateral pedicle, because at the end of this, after removing the facet, we probably will need to decompress the contralateral side. So that's why we need this. So this is a reconstruction of that CT after he marks these areas. So this is how the CT looks on sagittal. This is how it looks in the coronals. And this is how he can mark or not these areas into our field preoperatively, and then using, as I say at the beginning, bending this or blending this with a software, he's able to incorporate this into the OR. So this is how the room setup looks. The microscope, the intraoperative CT, the navigation camera, obviously looks a little bit crowded. But if you pay attention, it's the same setting as any kind of navigation case. The only difference here is that there is one reference array on the microscope and one reference array on the patient. So the infrared camera is looking at two references, and based on this, we're able to navigate. On the left here, you see the steps that we have in the TLIF booklet, and you see the starting point on the upper left and the ending point. And then on the lower image of the cartoon on the left side, you see the pedicles and the disc. And you see these points in the actual field on the right side. And this is how it looks during the surgery. So we are able to see this real time. And I'll show you a video. This is the case that I showed you before, which is the 57-year-old man with mechanical back pain and that small node there that we were trying to avoid. This is the CT scan, how it looked. during the surgery. And this is like the intraoperative image that we had. So we are able to point out that defect on the bone to try to avoid it when we're trying to place the cage. And also we can see the pedicles above and below and the disc as well. So we are able to navigate while we are still using the microscope. This is the calibration of the microscope. The reference, there's like a virtual image in the microscope, and then we calibrate that with the patient reference array. We identify the starting point, the ending point. As I said, this is not like we cannot do it without augmented reality, but this is extremely helpful. We have excellent feedback from junior residents that this is extremely helpful for them to understand the tubular approach, because we're using here sometimes an 18 millimeter tube or a 21 millimeter tube. And sometimes for the residents, even like the senior residents, they come and they ask me, hey, Rodrigo, how, I think I didn't do well. I went to the lab, but I still don't feel comfortable with this. And I understand, you know, as someone that just finished training very soon, I understand them. It's hard to work around it too. So this makes the workflow very efficiently. This is the facetectomy. Then we have exposed the dura, the pedicle above, the pedicle below. We identify the disc space. We drill whatever is left of that SAP. We identify where the disc is, where that defect is that we don't want to go to. And we put our expandable cage inside. We fill that expandable cage with bone, and that's it. So we're able to use this same kind of like logistics for tumors. This is a schwannoma, the lumbar spine. We're able to see that tumor on top of the lamina. We're able to see this reconstruction on the, even before starting the laminectomy. Once we expose the bone, we still know where the tumor is. Once we open the dura, obviously after this, there is shifting and we will see the tumor directly, right? But we can still use that, or we can actually remove it from our view. We don't have to see it all the time. So we can just use it depending if we need it or not, just as a reminder. And this is another case, an ACDF challenging case. We do the patient, we wanted to identify the vertebral bodies, the vertebral arteries, the discs. So this is how we incorporate everything. This is how it looks. If you want, as I say, if you want, we can incorporate the vertebral arteries. We can incorporate everything, so we can make our approach better. So just as a summary, how do I see the future of navigation and augmented reality? I think the merging of robotic surgery and active navigation is the future. I don't think that the current generation of robots it's enough. And I also think that the current generation of navigation is enough. But I see that the future is near, it's closer. And when we are able to merge this with endoscopic and big vision or pediatric scoliosis hardware, we will be excellent. And also when we were able to predict rod size, contour, bending, cage all at once. I know that there are softwares that can do this, but all are like in parts. You have to do every single thing in a different software. When you could do this all at once, I think that will be the next generation of navigation. And also when we these machines become available for every single center, and we are able to modulate the dose and use it on a case by case. I think this will be the next step. So I hope this was interesting to you. This is how we use it here. Thanks so much. This is Dr. Quiñones. Thanks so much for inviting me. This is before he started preparing to beat Canelo, but he looks good. And this is, I have to acknowledge my mentor here as well, Dr. Hartle. Thank you so much for inviting me.
Beautiful. Thank you, Rodrigo. You can see tons of questions right now, tons of comments. We have chats right here going on. They're very excited. I'm going to start with Dr. Nunmeyer, who also, by the way, he adjusted his schedule to be able to meet with you later at the time that Dr. Fox couldn't meet with you. So he's going to be able. Eric, go ahead. Take it away, champ.
Hey, Dr. Navarro Ramirez. You can tell Roger Hartle I said hi, first of all. But second of all, hey, where do you put the reference arc when you do your far lateral microdiscectomies? Are you putting on the spinous process or iliac crest or just on the skin?
We use the iliac crest for this. Since most of them are in the lumbar spine, as I said, like we have like 60 centimeters to work around. So we put it on the iliac crest and we're able to see almost like T12, T11. So it's pretty good with the iliac crest. So then we just drop the tube and that's it.
And then you guys are primarily using BrainLab for your image guided system?
Yeah, we use BrainLab and all our tools, at least from the Pew. I have no conflicts with these companies, at least from the Pew are navigated. But the BrainLab pointer I've noticed, I've used before in Montreal, I used the Medtronic pointer and it was a little bit more flimsy, I will say. The BrainLab, what I like about the BrainLab pointer is that it's very stiff. So for spine surgery, I think it's very helpful because you use it as a pointer, like a very hard tool.
Thank you.
Thank you, Dr.
No
Notmeyer. I see Dr. Chen already ready to rock and roll right there. He raised his hand. And if you want to make a question, please raise your hand. Take it away, Selby, please.
Well, thank you very much for that excellent talk. I just wanted to make a couple of comments, really. One, you mentioned how navigation can eliminate wrong level surgery. I'll say, well, I think that it can definitely decrease the risk or rate of wrong level surgery. I think it's certainly still possible, especially in the thoracic spine where the segments often look quite similar to each other, that it can still result in wrong level surgery. You know, if you're going for T7 instead of T8 and end up instrumenting, you know, the wrong level, it can certainly still happen. Secondly, you know, when you talk about augmented reality, I actually think you touched upon its greatest use, which is that of education. So for me, the greatest way to learn MIS spine surgery is actually open spine surgery so that you can actually see all the anatomic landmarks. But as we transition to more and more minimally invasive surgeries, residents may not necessarily be exposed to all the open anatomic landmarks you might see. And so when they start going into MIS, they may not have had that previous experience where they can visualize those other structures in their mind's eye. And so augmented reality will help them see that and better identify, you know, where the anatomic landmarks actually are. But I think you do make a great case for augmented reality.
Yeah, thank you so much. Those are great points. I think what you're saying is like, yes, at the end, we're still in the human factor. We have to rely on the human factor for robotics and for navigation. We cannot trust 100% on them. But the way we use navigation for thoracic cases is we always drop a pin. So whenever we are doing a case where it's going to be challenging to go back and forth and counting from the bottom top or the top bottom, whatever, we drop a pin. You know, we count, we make sure that everyone in the OR agrees. so we count and we make sure like, okay, this is T6, T7. Okay, we know it's T6. We identify it and we drop a pin. The same kind of routine that we use with the PARS preservation technique. So we drop a pin, and when we are sure that that's the thing, and if we are not sure if we cause like shifting during like the surgery, then we just rescan. You know, we are not like shy when it comes to rescan. With this machine, we can modulate the dose. That's something I didn't talk about, but I have it in the presentation. I just hide the slide. I didn't think that I had time, but what I want to acknowledge is that this machine is better, obviously, in terms of radiation exposure for the staff. There's a publication that just recently came out with, it's a 13-fold less radiation exposure for the surgical staff, effective dose. But for the patient, it's still double the dose in terms of radiation. So we cannot change that. And I think we have to work on that.
Beautiful comments. Excellent. And I thought that I saw Eric raising his hand. I want to make sure that I didn't miss. Eric, you didn't want to make another comment or another question. I saw you raising your hand.
No, I didn't. I'm sorry, it was a mistake.
Thank you. Wonderful. Well, Rodrigo, thank you. This is an amazing topic for us, of course, and trying to figure out how we move the field. You saw some of the topics that were published, and our team has published some of the grants that they're applying for. So we're really, really excited about the future of navigation, robotic. You may or may not know Dr. Nat Meyer has been a leader. He's actually one of the inventors of the original, robotic system and some of the devices. So beautiful work that he did here early on when he was a junior faculty at the Mayo Clinic, collaborating with the people at Barrow where he did his fellowship. So there's a lot of interest here for that kind of stuff. I saw Dr. Pires, he had to leave. Actually, he was one of our colleagues, also spent time with us. He works in one of the hospitals. Wants to connect with you. So I'm going to connect you guys via email as well. So you guys can talk to each other. He may be interested in coming to visit you guys and Cornell and see how you guys are doing this. So thank you, Rodrigo. So we had an amazing morning. We had over 9 countries represented this morning. I saw the summary right there by Dr. De Biase. We had Colombia, Dominican Republic, India, Italy, Mexico, Pakistan, Panama, Spain, and of course the United States represented this morning, joining us from all over the world. And we had tons of participants. We're very excited. I saw your schedule. We're scheduled for you and I to connect another, and then you can have. We appreciate the fact that you dedicate this morning to us so you can learn about what we're doing. So thank you. I'll see you in a few minutes. I'm going to go ahead and connect, right now to our next meeting. And thanks everybody for meeting with Dr. Navarro. And we thank everybody for your time in this morning, and looking forward to Friday and then next Monday. Thanks everybody. Bye-bye.